So again, it's very exciting to be able to have this interpretation, and a very warm welcome to all of you joining us today. It's a great program. Most of you know the ICMLF and our programs. We are a not-for-profit foundation, really with the goal to improve CML outcomes around the world. And we do this through CML education, our programs, our webinars, our sharing of best practice and of clinical papers, goes right through our entire reason of being. And it's great that these regional discussions are part of this. We also have a global research programs, again, which many of you and your centers are involved in. We are looking at the genomics of CML, treatment-free remission, CML and hepatitis B, and pediatric reviews in CML. So that's really about the ICMLF. Arlene will go through at the end how to join the ICMLF and keep in touch with our programs and continue to work with us. But for today, again, welcome to this second regional discussion group. We are talking about TKI choice and managing the chronic effects of TKI therapy. And I will now hand over to our host, so Arlene, who is our moderator for today. Thank you, Arlene.
Thank you, Nicola, and hello and welcome, everyone. So nice to see so many familiar names and faces coming up here, and some new ones too, so welcome. So before introducing our experts today, let me cover off on some logistics and housekeeping. So firstly, we want these discussions to be interactive and inclusive, so you will have the opportunity to ask questions and raise issues, but for everyone's comfort, please keep your microphone switched off until you actually want to be heard. By contrast, it's really nice for our speakers and for me to feel like we have a real audience that we can interact with. So you're very welcome to leave your cameras on. You can ask questions throughout the discussion, either by using the chat function or by raising your hand. It's easier for me if you actually use the chat. And of course, we have simultaneous interpretation. You're free to speak in the language in which you're most familiar and most comfortable. Any questions about logistics, please get in touch with Nicola. Questions about interpretation, Livia Case, please. Okay, thank you. So our first topic for discussion today, please, Nicola, if you could move the slide, is TKI choice and sequencing of treatment in a world of increasing options. And it's a great pleasure to introduce our international expert, Associate Professor David Yeung from Adelaide in Australia. David is preceded by his reputation, widely known, highly respected around the globe as a clinical and a laboratory hematologist. He is here by popular demand, and this is actually his debut as in one of our regional key discussions. So David, welcome. I hope it's the first of many opportunities to learn from you.
Thank you for the very kind introduction, and I'm very glad and honored to be invited.
We're honored to have you here. And our regional expert for this topic is Dr. Lilian Pilleux from Valdivia in Chile. Lilian is another great physician and researcher. She sits on the steering committee for these Latin American key discussions and is massively supportive of the foundation. Lovely to have you presenting today. Welcome, Lilian. So nice to have you here.
For me, it's an honor also to be here, especially with Dr. Yeung, whom I met years ago. I would like to say good morning to Nicola, Arlene, and Dr. Yeung, and good evening to Dr. Lipton and Katia, and to all my Latin American colleagues.
That's great. So Lilian was having some problems getting her slides up. So I wonder, Nicola, if you could run Lilian's slides for her. And as you're getting those slides up, I'll let the audience know how we'll run this session.
Arlene,
So,
sorry, can I just interrupt? Lilian mentioned that she and I met years ago, and I just would like to clarify that it was all thanks to the International CML Foundation that invited Lilian over to visit Adelaide, and we had a great working relationship when she visited. And yes, a big thank you for bringing collaborations together to the CML Foundation.
And collaboration and bringing people together is a huge part of what we're about. So I'm glad we're putting the band back together today. So Lilian will spend a couple of minutes identifying key issues and challenges in TKI choice and sequencing in the Latin America region. Then she'll share a case that illustrates some of these key issues, to which David will respond. We'll open up to audience for questions. Lilian will present a second case, David will respond, and we'll open up to the audience for a broader discussion around the topic. And finally, I'll introduce the speakers for our next topic when we get to it. But for now, I'd like to acknowledge that Dr. Jeff Lipton and Dr. Katia Pagnano are in the audience already, and we welcome any contribution you'd like to make to this topic discussion as well. You are all experts in the field. Okay, Lilian, are you ready to go?
Yes.
Great.
Well, today I will start my presentation by showing how TKI choice and sequencing is working in Chile and Latin America, specifically in Argentina, Colombia, and Brazil, from where I could obtain direct information. Next slide. Well, Chile is a small and long country with a population of 17.5 million. The health system works with 80% of the population being attended in the public system and 20% in the private. We have a special kind of law that is called explicit health guarantees, within which leukemias have certain diagnostic tests and treatments that are covered by law. Funding for CML considers around $3,500 a month, and private patients have to pay the 20% of their drugs. Drugs formally included are imatinib, nilotinib, and dasatinib. The choice of which TKI is used are the ones recommended by the European Leukemia Net and NCCN, and is limited for the drugs specifically mentioned above, but we can obtain the other drugs with special paperwork. The next slide. First-line therapy is guided by prognostic scores and individual patient characteristics. If the patient is a good candidate for future TFI, we choose second-generation TKIs. And if TFR is not a goal and the patient is elderly or has comorbidities that put the patient at risk, we choose imatinib. For second line, we have dasatinib and nilotinib available everywhere, and in public hospitals, according to its local administration, we can obtain bosutinib and ponatinib relatively fast. And some hospitals, we can also obtain asciminib. In the public hospitals, qPCR for follow-up every 3 months is financed, but limited for monthly follow-up in some centers because of the time of the results. In the private patients, it has to be financed by the patient, since the law only covers the cost of qualitative PCR. Well, I made a small survey with my colleagues of Argentina, Colombia, and Brazil, and compared the TKIs that are available. And for first line in Argentina, they have imatinib, nilotinib, and dasatinib, and also bosutinib for first line. And for second line, they have all the TKIs, but asciminib is available in the majority of centers, but not in all. And an issue they have is that all the TKIs have many copies. So the patient is switched from one brand to another. In Brazil, in first line, they have imatinib. They have nilotinib and dasatinib approved in your country, but it's not financed in first line in the public system, only in the private one. For second line, they have nilotinib and dasatinib for the public system, and bosutinib, ponatinib, and asciminib are available only in the private system, but are not reimbursed. In Chile, in first line, we are the same as in Argentina, and second line also. And the access to ponatinib and asciminib is available, but it's a bit slower to obtain. And in Colombia, they have access to all the TKIs in first and second line and third, but the supply in the public system is irregular. Next slide. Next slide, please. Molecular tests available in the different countries are the following. In Argentina, they have a qPCR is implemented. Well, it's implemented in all the countries and available every 3 months in all. But in Brazil, they have certain difficulties performing it every 3 months. And in Argentina, a monthly follow-up is available, but the access also is difficult, as in Chile and Colombia. In Brazil, they don't have secure access for monthly follow-up. ABL sequencing is not available except for Chile, where in the public system, it has to be solicited through a certain work, but it's accessible. In the private system, the patient has to pay that test. Next slide, or here comes the first. No, there's one slide left. So the unmet needs and challenges, in my opinion, are in Latin America that qPCR access exists, but is limited by cost, especially in the public system in most countries. ABL sequencing is available only in Chile for all patients within the countries I analyzed, but not reimbursed in the private system. Access to third-line TKI is limited also. And the last thing is that there are insufficient hematologists or specialized nurses for optimal monitoring of therapy, especially in the TFR setting. And that's all for the first part.
So your first case?
Do I continue with the first case?
Yes, please.
Okay. Well, the first case that I have chosen is a patient of mine is now 70 years old. He's from Valdivia, and in July 2019 had a history of 12 months of general malaise and weight loss of approximately 9 kilograms, anorexia without fever or sweating, and the symptoms had increased in the last 2 months. He was a carrier of moderate obesity and had a history of smoking. On physical exam, he had a spleen 4 centimeters under costal margin. His hemogram at his diagnosis, he had a mild anemia and 293,000 white blood cells with 667,000 platelets. He was hospitalized and began hydroxyurea and prevention of tumor lysis syndrome. And the study was compatible with CML in chronic phase, with quality PCR for translocation 922 positive and 100% Philadelphia in the karyogram. Next. So the diagnosis of CML chronic phase high risk score was made. We chose to start with dasatinib 100 milligrams a day, which he tolerated. And he had an echocardiogram that showed he had left ventricular hypertrophy without systolic dysfunction. And before hospital discharge, he had lowered his white blood count to 157,000. So he started his outpatient controls, and at 3 months, he had a complete hematological response, and his qPCR was on 71% and had no cytogenetic response. At 6 months, he had a qPCR of 52.6%, and we decided to wait another control, and at 9 months, he had a qPCR of 32%. So here's the part for discussion.
So David, what do you think?
I think this is something that we come across quite often as patients are getting diagnosed older. In Australia, especially, the median age of diagnosis is 50 to 60. So it's not uncommon that we come across patients that are a bit older and with cardiovascular comorbidities. I think that going back to the topic, though, the conversation is about picking a TKI up front. And as many of you know, the considerations here is to balance disease progression risk versus comorbidities and trying to achieve a deep molecular response with a view to TFR. So I think we can all agree on that. So on the one hand, this gentleman has a disease risk that's high. Firstly, I don't know, but it seems as if he's had symptoms for a year before his diagnosis, and he may have had the disease for 12 months, and thus qualifying him for what we used to call late chronic phase. The second thing is that he's got a high SoCal risk and a high ELTS score, both of which places him at the higher end of the risk of disease progression. On the other hand, he also has risk factors for comorbidities such as obesity, diabetes. And when I see an echocardiogram with an ejection fraction of 70% in a 70-year-old, I get very suspicious because, as you have rightly said, Lilian, this is a sign of diastolic dysfunction. It's not a sign of good cardiac function. It's a sign of diastolic dysfunction. So on balance, thinking about those two factors, I think the choice of dasatinib is good because picking imatinib would risk disease progression. Picking lorlatinib will risk cardiovascular side effects. So dasatinib is a good choice. However, we also know that this drug, it can be a bit trickier to use in the elderly because it has a risk of pleural effusion. And then after you started therapy, looking at the BCR-ABL going from very high to 70 to 50 to 30, it is falling, but it's falling at a rate that's very slow. And my heart sort of sinks when I see those numbers, because if you join the dots, using this drug, he would take years to just get to less than 1%. And obviously his risk of transformation is high with those kinetics. I was surprised that the fish only have 50% Philadelphia chromosome positive, because with a BCR-ABL of 32%, I would have predicted a bit higher. What would I do now? I would, as you've done, I would have done the bone marrow looking at for cytogenetics additional chromosomal abnormalities or clonal evolution, I would have revisited compliance and make sure that there are no concomitant drugs. I don't know how common it is in the Latin American population to actually take over-the-counter medications such as herbal remedies, which may have a drug interaction with dasatinib. And I would do mutation analysis. I don't know, I mean, this was back in 2019. I don't know if you had mutation analysis readily available to you, but I would have done it at 3 months and then again at either 6 or 9 months or both, because this kinetics is very slow.
Lilian, how does that sound? And also, would you like to take the question from Virgilio Salinas in the chat?
I don't see the question, but in that time we didn't have studies for ABL mutations, so it wasn't performed. We just made the cytogenetic tests. We could send the test to another city, to Santiago in that time, but it wasn't performed. I don't see the question. It's in Portuguese.
Katia, do you want to translate?
Let me see if I can see the question.
Virgilio Salinas.
It's not in
Spanish.
Portuguese, it's in Spanish.
No, I can't find the question. Where is the question? I'm
Yes.
scrolling.
Would you like to translate it for us?
No, I can't see the question.
Oh,
It's not-
I found it. It says he's worried about it going so slow. The same commentary as the
Okay.
the mutations for ABL were made.
I think you have already answered this question.
Yes.
So
So
Lilian,
the patient, we really didn't have know what other TKI to use. Because we didn't want to use nilotinib and didn't have experience with bosutinib in that time.
yes.
So we waited 3 more months, and because of the cardiovascular risks.
Yeah,
I
I
don't
think it's
know if
difficult. I think it's difficult, isn't it? Because even if you were switching to nilotinib, even if you had no cardiovascular risk factors, I don't know that the evidence is very strong switching between second generation TKIs. So I don't know what the probability of success is, even if you were to say less switching to nilotinib.
between you, including bosutinib?
Well, bosutinib is a different case, isn't it? Because as you have mentioned, I think the FDA explicitly endorses bosutinib in the 3rd line setting as an indicated drug, but I still don't know what the success rate of switching from dasatinib to bosutinib is in a case with primary resistance. I don't think the data is there for us to say whether it works or not. But as you said, it has a label. It was compared, as you know, against asciminib in the 3rd line setting in dasatinib and nilotinib failures. And yes, there is some efficacy there. I think Katia has her hand up.
She does. I'm going to ask Nicola to get the slides up again. We do need to sort of move on. However, as Nicola's getting the slides up, both Jeff and Katia have their hands up. Let's go Katia first, and then Jeff, please, and then we'll move on.
Okay, just a quick question, going back to the 1st line setting. He was treated with dasatinib, but however, bosutinib could be a good choice for 1st line treatment for this patient with comorbidities. Do you agree, David and Lilian?
Which one?
Bosutinib would be a choice for the 1st line if available. What do you think about it?
Retrospectively, yes, but in Chile, I don't know anyone who has used bosutinib in first line yet.
Oh, yes, of course, because you don't have
So,
access. But
we prefer something that we
if
know.
you could choose another option, it could be a choice.
Yeah, I agree with Lilian. I have very little with experience with bosutinib as well in the first line because we just can't get our hands on it.
So Jeff, and then can we move on to Lilian's second case, please?
Bosutinib would have been a good choice, but I just want to reinforce what David said. In the absence of specific mutations that might allow you to switch from one second generation drug to another, the chance of responding with a second generation after failing one second generation is probably less than 10%. If I was to go on to a second line of treatment here, well, I have less experience with asciminib, but even in this individual with their comorbidities, I would have gone to ponatinib at 30 milligrams daily. And with the study that's out there, if there's a response, drop down to 15. And you can get away with it with this man's risk factors.
We changed to bosutinib, and that time we indicated 500 milligrams a day. And in the first control 3 weeks, he was asymptomatic and had a normal biochemical profile. But he was then, it came 2 months later and was feeling nauseous and had an increase in transaminases with an ALT of 400 and a AST of 700, and also had a fall in the platelet count. So I have another break if you want to discuss the toxicities, or do we move on to the last one?
I think if we could move on to your second case, please. There's always so much really interesting discussion and we fall behind, but we'll bear those things in mind. If we could move on to the next case, but do feel free to come back later in the discussion with any outstanding questions.
Okay, I'll tell you then what happened later. And the second case is a 55-year-old woman from Puerto Montt, that's a city like 200 kilometers away. She was diagnosed as CML in 2004 at the age of 37 and started hydroxyurea. And in 2007 was referred to Valdivia. At that time, we could apply here to GPAP, and she started imatinib. 2 years later, she didn't have cytogenetic response and was switched to dasatinib. In that time, we performed the PCR for T315I, that was not detected. We didn't have sequencing. But with dasatinib, she had frequent headaches and had irregular therapy adherence. In the next years, she maintained 100% Philadelphia positive in the cytogenetic studies. And in 2010, she was studied for bone marrow transplant, had a brother that was compatible. And we proposed that to the Ministry of Health, but they suggested to switch to nilotinib therapy, which she started in December 2010. So she didn't have a cytogenetic response, and we started then doing study for ABL gene mutations in Santiago. And afterwards, she widowed and became irregular her controls again. She didn't have any gene mutations. So she maintained the next years no cytogenetic response with qPCRs above 1% and no mutations detected. We tried to, in that time, again with dasatinib without any good response, just the hematological response. Just one control, she had partial cytogenetic response. So we switched back to nilotinib and she stayed the same, just achieving MR1. So finally, in 2019, there was a clinical trial for ponatinib, and she started it, but did not tolerate 45 milligrams a day because of edema, severe arterial hypertension, and headache. She was reduced to 20 milligrams and then 10 milligrams a day. She lost hematological response for 3 months, which she recovered. She had been diagnosed diabetes and was taking antihypertensive therapy. In 2022, after the pandemic, she returns to Valdivia Hospital with a normal blood count, but with a qPCR that stays up in 26.2%, with 10% of Philadelphia in the karyogram.
What do you think, David?
And another very difficult case, Lilian. You dragged out all the very difficult cases, isn't it? I think, you know, this woman, you know, despite her poor control of the disease, she was diagnosed in 2004, and you've gotten her through to 2022, and that's really a good result. But however, if we actually look at the BCR-ABL, with, as you said, it does fluctuate, and this woman has a history of a mixture of both intolerance and resistance. So compared to the first case, where there is a very strong feeling of primary resistance, this woman, I'm not so sure. I do think that there is resistance there, but I'm not sure how much of it is also intolerance as well. One of the trickier side effects that I find is thrombocytopenia, because it limits your capacity to maintain dose intensity. If we have to stop drug all the time for neutropenia and thrombocytopenia, you don't actually know how much drug you're actually getting to the system to eradicate the BCR-ABL. I suspect, you know, your proposal for an allograft probably was justified. I don't know how it works in your country, how the Ministry of Health allocate allografting resources. But I also think that going from imatinib to dasatinib was a good choice. Going from dasatinib to lorlatinib, I don't know how much mileage you will get from that. As Jeff has said, switching between second generation TKIs, we don't think that's, we think it's worth trying, but we don't have much expectation of success. And then going from nilotinib to ponatinib, I think is absolutely indicated in this instance. And the doses is, as Jeff has said, in the OPTIC study, in which he is a co-author on, started, you know, you've started at 45 there, that's fine. As soon as you've achieved a response, you drop the dose down to 15. But I note that in this particular case, you had to dose reduce for side effects anyway. It is tricky. I think in 2024, we know what the next step will be. We know what the answer is in terms of the next drug to try. But back in 2022, it would have been a bit more difficult, because ponatinib, unless you go to bosutinib, which again, you know, there's no evidence for that, but ponatinib back in 2019 would have been one of the last TKIs that we have access to.
Lilian, you've got quite a bit more of this case to go, haven't you?
Yes, in the year that we chose ponatinib, ponatinib was not available in the public system. It was obtained only through the trial, and bosutinib hadn't got to Chile yet. So that was the reason we switched from one second generation TKI to the other. This one is the final evolution after she started ponatinib. There was no, this is a qPCR, and it didn't go down very much. But last year she started asciminib, 40 milligrams every 12 hours with excellent tolerance. And at the moment she has achieved MR2 with a qPCR of 016 with mild hypertension and a regular control of her diabetes and dyslipidemia. So she's going better until now.
That's really good news.
I hope she can obtain MR3 the next month, also the next control. But it also it has been very slow, so we can't, landmarks for the European Leukemia Net on second or third line, I don't know, wouldn't be met either.
Yeah, no, she was diagnosed in 2004. It took her 20 years to get to MMR, but you got her there, so great.
Jeff and Katia, do you have any comments on this case? And we're open to the audience as well.
I would watch very carefully whether the bit of a blip at the end means it's only been transient. We don't know, but I think we forget one thing. You go back and look at data that came out of MD Anderson, published maybe about 10 years ago. I think it was Lancet Hematology. They showed with 10 years of follow-up, patients who, with imatinib, who got a 2-log reduction or 1% versus a 5-log reduction of 0.01%, the survival of these patients at 10 years was about 95 plus or minus 2 or 3%. So you do not have to shoot for the Holy Grail and get a long-term survival. This woman also has wonderfully good chronic disease. She has close to 20 years until she got her first molecular response. Remember, there are some people, even now, survivors still of Hiroshima in chronic phase who've never really got great responses who are still alive. The survival curve is asymptotic, and this may be one of these long-term survivors that it doesn't really matter how good a response. I think if you've got a response where you are now, I wouldn't blink. I'd leave her where she is. You're never going to get to a TFR state. There's no data for TFR in a case like this. And if she's stable, she's going to live an otherwise normal life as long as her other comorbidities don't catch up with her.
Okay. I had a question about the ponatinib dose. In the time she was receiving 10 milligrams a day, would you have maintained that drug, or would you have gone back to the other TKIs?
Well, experience with ponatinib, I'm surprised you got 10 milligrams because it's supposedly is not commercially available. If you look at the optic study that David and I alluded to, there were 3 starting doses, 45, 30, and 15. And the only time where 45 really made a difference in the outcome was with the T315Is. Starting at 30 milligrams or even 15, the outcomes were pretty well just as good. So I might have held her at 10 or 15 milligrams and seen how she does.
Okay, thank you.
Lilian, I have a patient that is she didn't tolerate well ponatinib. We started dose reduction, and now she's stable with complete cytogenetic response with 15 in alternate days, 50 milligrams in alternate days. So some patients you can keep low doses for a long time. And
there are rules, and there is art, and that is the art of it. And that's why I still think most CML patients require a CML physician to get in there and do the maneuvering of this.
Indeed.
Absolutely agree.
Carla Bocampani has asked a question on the chat. In case of failure to second generation TKIs in second line without mutation, would you choose asciminib before ponatinib? We might start with David.
I think that is the I think that is the multi-million-dollar question that Takeda and Novartis would like to settle without a head-to-head comparison. Without a head-to-head comparison, I think that's tricky. But as we have illustrated in these couple of cases, I think the decision would hinge on a patient's comorbidities and whether you think they have more of a primary resistance that would place them at high risk for disease progression to blastic phase, and whether you have specific mutations to target. I think, and this is my personal opinion, I think if it is a patient with high risk of cardiovascular disease, all things being equal, I would probably try to use asciminib first. Whereas in a patient who is a bit younger, because the data for ponatinib is actually quite strong for accelerated phase and blastic phase disease, someone who has really aggressive disease who's a bit younger, I probably would start off with ponatinib. But yeah, I'd be interested to see what others think.
Jeff, what do you think?
I'm sorry, I'm having trouble. I guess it's a matter where which team you're on. I have been on quite supportive of the ponatinib data, and I would use ponatinib in most cases, and I've used it in people with other high-risk disease and cardiovascular. I think one of the things, asciminib is a very good drug. One of the things we do not have, like we have with the other drugs, is long-term side effect data going out some years like the others. We just don't have it. And the things starting to pop up, that may or may not be significant, and I don't know the answer to that. I think you as whoever's the treating physician should choose one or the other and use what you're comfortable with, unless there's some major contraindication to using one drug or the other. I think that's important to also, not just what the patient wants, but what you're comfortable with and comfortable with watching for those adverse events in that particular drug. So I think either might be very good. I think getting back to what we said originally, a second gen after a second gen in the absence of a directing mutation is probably not a great idea.
Lily, I'm conscious that because we were running short of time, I sort of cut you short a little bit on the on your case one. Do feel free, please, to tell us how that turned out.
I had a slide that showed his qPCR, but he was reinitiated. He suspended bosutinib for a month and then started it at half dose and started going up once again his transaminase, and we didn't have the 100 milligram tablet, so it was like a month after 250 milligrams and new suspension that he started with 100. And progressively we increased the dose, and after 18 months we achieved the 400 milligram dose. So the dates on the chart are a little bit wrong, but the last control is this year, and he had achieved a major molecular response in the beginning of this year. Even though he had received 400 milligrams only the last 6 months before that test. So there was a question I wanted to do about the optimal dose of bosutinib, and if you can use it at low doses, it still controls the disease. Apparently, this case illustrates that.
I guess perhaps I have more experience with bosutinib than David, it sounds like. One of the things that we've learned with bosutinib is the whole ramping up phenomenon, starting at a low dose and moving up on the dose over a very period of time, which could be as short as 3 days up to a few weeks, will often alleviate the very early side effects of the hepatitis and the diarrhea and control the drug. If you go back and look at the studies that are out there, the before study and everything else, many of those patients assumed control with 200 or 300 milligrams a day. They did not need 400, did not need 500. Bosutinib also very much has a racial issue. I don't know the racial background of your particular patients, but particularly in Asians, they don't tolerate the full doses. I have MR5s or better on 200 milligrams in a number of Chinese patients, because that's all they need. So again, this is a case where you have the product monograph and you're jammed with the monograph. Unfortunately, you didn't have the 100 milligrams, which is unfortunate. I have rarely in the last few years used 500. And most of my bosutinib patients are on 200 or 300 milligrams a day with at least 0.01% or better.
I think he was one of the first patients here in my hospital with bosutinib. So later the studies demonstrated that we can use 400 safely. So I think it's better. There's a proposition to start with lower doses, and I think that would be the best for future patients.
There's a question that's come up from Ana Inés Prado in the chat. Are you considering an allogeneic transplant after failure of 2 lines of TKI, or would you rather try ponatinib or asciminib?
Is that a question for David?
Yeah, well, I think for me, I would, even if I was looking around for donors, I would still try to use ponatinib or asciminib, because the first thing to say is that, I mean, even allogeneic stem cell transplants in experience centers do get very good results. It is still no walk in the park. We just did a 40-year-old man an allogeneic stem cell transplant, and who was refractory to everything, including ponatinib and asciminib. He went through his transplant very well, but he then had to have a 3-month hospital stay for stage 4 gut graft versus host disease and skin graft versus host disease. So that's just a reminder that even though we get patients through, it's still a very resource intensive, highly risky and toxic therapy. But we still do them in Adelaide for patients who are fit and who has otherwise long life expectancy, in which there's no expectation that controlling the disease with TKI will be sufficient. But yes, absolutely, we'll try ponatinib and or asciminib. Interferon, we haven't had great experience with in terms of getting efficacy. So we tend not to subject our patients to a trial with interferon, but yes, you're right. In many places, I think that remains a possible therapeutic line.
Are you performing sequencing studies or for patients that are resistant to therapy to decide if he or she has to go to transplant, like some certain mutations that are prognostic?
Yeah, so I assume, Lilian, you're talking about mutations other than BCR-ABL.
Other than ABL, yes.
Such as ASXL1 and RUNX1. We do have access to a mutation panel. You know, the great benefit of working in the same city as Sue Branford is that we have access to a number of very good mutation analyses facilities. So and in Australia, the government is generous enough to actually fund a next generation sequencing based assay for or myeloid diseases. So yes, we are looking, Lilian, at mutations in other myeloid genes, such as ASXL1, RUNX1, BCOL1, etc., etc. But I still think that is probably, we're doing it mainly for research purposes rather than to guide therapy.
Can I
Thanks,
comment?
Jeff.
Half my life was spent as a transplanter, so I have about 3,000 of those behind me as well. So one of the things I say about CML is in the past decade, other than people in second chronic phase or beyond, or maybe 1 or 2 patients a year who get transplanted with CML because of chronic hematologic toxicity. I cannot sustain a TKI because they keep becoming thrombocytopenic or something to the point where we have to stop their drug. I have not done a stem cell allograft for CML in chronic phase. You know, the other options invariably work. So I think you should try them all. But if you've got persistent hematologic toxicities with drugs, it's not going to get any better. They don't have any normal stem cells left, or they've gone through an advanced phase. You know, it should be there in the back of your mind, but we just haven't had to use it.
Yeah, I agree. The 2 that we did in the last 3-4 years both had significant hematological toxicities, and we just couldn't dose them.
Exactly.
Such a fantastic discussion as always, and we are well and truly out of time for our TKI choice and sequencing topic, I'm afraid. Thank you very much, Associate Professor David Yeung and Dr. Lilian Pilleux, for your insight and wisdom and a great discussion there. Okay, so we will move on to our second topic for today, managing the chronic effects of TKI therapy. And it's my very great pleasure to introduce Dr. Jeff Lipton from Toronto in Canada. Jeff is a giant in the field, and he's my go-to person for really difficult cases and questions that have other people scratching their heads. Now, apparently he's trying to retire, but I hope that just means that he will have more time to contribute to the foundation and to events like this. Such a privilege to have you here today, Jeff. Welcome. And finally, I'm delighted to welcome Dr. Katia Pagnano from Campinas in Brazil. Katia is another leading physician and researcher, and also on the steering committee for these Latin American discussions, and a great friend of the foundation. I had the pleasure of climbing for a cure with Katia last year in Nepal, as well as touring the Valdivia Hospital in Kathmandu. And with her, I discovered that she's great company and has a fantastic sense of humor. I'm delighted that you're here. So Katia, if you could share your slides with us, please. And as you're getting your slides up, I'll share with the audience that we'll run this session similar to the last one. Katia will spend a couple of minutes identifying key issues and problems in the area, present a case that Jeff will respond to, a second case that Jeff will respond to, but we welcome David and Lilian's contribution to those as well. You're all experts in the field, and audience, please come forward with your questions and comments. As Katia is getting her slides up, I'll also say that
I'd like to thank you for the kind introduction, and to thank you everybody who's watching. Say hi to Lilian, Dr. Lipton, and Dr. Dave Yeung. I'd like to share, I'm not seeing the sharing, it's different from the one that we have checked before the presentation. If somebody could help me, because this is not the same, it's not the same screen I was seeing before. No, it's okay. You're doing to me. Okay, thank you, Nicola. I have replaced one slide in the new presentation, but that's okay. Okay, no problem.
Thank you, Katia.
Let's go back to the first one. So today I'm going to discuss with you some cases of chronic side effects of TKI. That's after treating patients for many years that we start seeing many of these late chronic effects. Next, please. Next, please. Next slide. Who is passing the slide for me? It's not me. Okay, thank you. We have discussed before, these are all the TKIs we have available today. Most of them, they have the the mechanism of action that inhibits the target site, the ATP binding site, and now asciminib that has a different mechanism of action. The spectrum of mutations that the TKI inhibit is sometimes different, so it helps us to choose between them. Next, please. But the problem with the TKI is that they don't just inhibit BCR-ABL, they inhibit several other kinases, and that's why that we have the adverse events because of this off-target inhibition of the other kinase. Next, please. This table is very known for everybody, but just to show that we have several side effects with all TKIs. The first that I'd like to mention is the hematologic toxicity that Jeff just told us. All TKIs can cause thrombocytopenia and neutropenia. It's more severe if the patient's in the advanced phase, but this is a problem that we have sometimes patients that do not tolerate any TKI because of thrombocytopenia mainly. So this is a case that we have discussed that could be to go to a bone marrow transplantation. But for example, for imatinib, we have several effects, but not so much cardiac events like we have with nilotinib and ponatinib, and also some other adverse events specific, for example, for dasatinib, the pleural effusion, from to bosutinib, the gastrointestinal side effects. And so we're going to discuss some of these events in the case presentation. Next. So this is the situation today. We have patients that are living many, many years with the life expectancy approaching the normal population. Here's the data from the German trials showing that the survival in 10 years is in CML patients is 89%. So we see those kind of patients every day in our clinics. Next. So that's the cost of taking TKI for the whole life. Only 20% of the patients will be able to stop treatment to try TFR. So the majority of the patients, we have to take some kind of medication during his lifetime. So we have the side effects. The side effects may affect by patient adherence. This may also interfere with the response of the patient. And so we have to manage these long-term side effects. Next. So this is the first case I would like to show you. It's a young patient that diagnosis. She was a teenager, 16 years old in 1997. So she had CML before the TKI era. So she was treated with interferon from 1997 to 2002. Then when imatinib became available in Brazil in 2002, we started imatinib for 100 milligrams a day. But she had a response. She didn't have a cytogenetic response. In 2005, she lost a hematologic response, and we identified this mutation, E255K. At that time, there was no, dasatinib was not approved. We have the BMS trial, so she was included in the accelerated phase arm of dasatinib 140 milligrams a day. And she took dasatinib, this dose from 2005 to 2011, and she had a very good response. She achieved MR4, and she didn't have dose reduction because of other toxicities. She tolerated very well. Then she got pregnant in 2011. And when she got pregnant, we had to interrupt dasatinib. And during the interruption, she lost the major molecular response. So we treated her with interferon alpha during the whole pregnancy. And when the baby was born, we started again dasatinib, and she recovered the MR4. Next, please. So she came to her regular appointment in 2019. This was 7 years later. And she was complaining of dyspnea for climbing stairs. And then she was worsening of the symptoms in the last days. And even when she was resting, she had a cough, and she noted edema in her legs. And then in the physical examination, we saw that she had a pleural effusion. It was confirmed by X-ray and CT. And then in the echocardiogram, she had a right ventricular dysfunction and a severe pulmonary hypertension. His pressure of the pulmonary artery was 90 milligrams. And so we had to discontinue imatinib definitively. In the next month, after she recovered of all these symptoms and of the pleural effusion, she started nilotinib 400 milligrams twice a day. And in about 2 years, she developed dyslipidemia. It's a common side effect of nilotinib, and also had a skin rash, but it was very mild. We started statin for her next. And this is just to show this toxicity that I mentioned about the pleural effusion. It's a very common toxicity when you treat patients with dasatinib. It doesn't matter the time of the treatment. Patient may have in the first years, after 10 years, like this patient, in about 28% of the patients that use dasatinib in first line has this side effect. And this pleural effusion increases with age. And 5% of the patients in the decision trial, it was a trial that compared imatinib in first line with dasatinib, had pulmonary hypertension. In the latest years, the Anderson showed a strategy of starting treatment with 50 milligrams a day. And the pleural effusion incidence was lower, only 6%. And also, the DAVLEC trial that was conducted in Japan showed that in elderly patients, if you treat with lower doses, like 20 milligrams a day, and then you increase if necessary, patients achieve very good response with only 80% of chance of having pleural effusion. But remember that this patient, it was a clinical trial patient in the beginning, and she was an accelerated phase when she started the treatment. And then she tolerated this dose for many years without no adverse events. Next, please. So for this case, I have some questions from Dr. Lipton and for the other participants. If today I have all available all TKIs, which TKI would you prefer to use in this situation? If this is a primary refractory patient, resistant to imatinib, with failure, intolerance to dasatinib, which TKI would you choose instead of nilotinib? This is the first question. The second question would be, if this patient will not be able to try TFR because she already stopped treatment when she was pregnant and she lost the response. So what TKI would you pick for the long-term treatment? Remember, she's a young patient. She's now 41, so she has many years of life to go. And if I have to reduce nilotinib dose, when would be the better moment to reduce? How much would you expect to reduce the dose? She's, until now, the only side effect she has from nilotinib is increasing the cholesterol levels. That's controlled with statin. And the previous mutation that we have identified in the past would affect your alternative TKI choice. These are the questions I have for the audience and for the speakers.
Let's start with Jeff.
So these are great questions. I think one of the problems is the pulmonary hypertension definitely is related to the dose of the drug. And I think there are very few of us today would take a chronic phase patient and start them at any dose higher than 50 milligrams. I think the days of using even 100 milligrams, which is on the package, monographed, are gone. Most of us would use 50, at most 70. And once if you started higher than 50, reduce the dose to 50. As the MD Anderson data showed, the incidence of pleural effusions is very much reduced. Now, remember one thing about the pleural effusions, it's not a cardiovascular problem, it is an immune problem. And there's a lot of work particularly done by the group in Finland has shown that it's related to NK cells. So some kind of immune response with the pleural being an innocent bystander. Getting that, I just want to jump and say the drug you would not use here would be bosutinib. is a drug of a similar class. There are now a number of reports of pleural effusions occurring in patients on bosutinib who've had previous ones with dasatinib. With that said, again, go back and look at the product monograph in the original Gleevec, and pleural effusions were there as well. So there's no of these side effects that are unique to any of the drugs, are just more commonly, particularly dasatinib, than any of the others. So that is what I would have done, and unfortunately the dose was high, and I think that's gone. I don't think she needs 400 twice a day. In fact, if you go look at the 10-year INEST-ND data results, the incidence of cardiovascular events in the 400 milligrams twice a day arm was almost 25%. Profoundly high. And that's why the starting dose of nilotinib, for instance, is 300 twice a day. I'm not sure why she was started on 400, because she really wasn't resistant. She was intolerant to what was going on. So I would have gone to 300. That's fine. I think it's time to reduce. And I would reduce stepwise. For instance, she said 400 twice a day. I would probably go to 300 twice a day. Make sure there's no loss of response over the next 6 months. Then from 300 twice a day, I could go down to 450 once a day. And I'm not pulling that dose out of a hat. If you look at the INEST-ND study, that was the fallback arm for patients who didn't tolerate 300 twice a day. So that's there. And if that is tolerated again for another 6 months with no loss of response, consider going down to 400 once a day. And some of these people could be maintained in doses as low as 300 or even 200 once a day. You're now talking of a maintenance dose, not an induction, because she has the response. The other thing is, I'm not sure that there'd be anything left of the 255 mutation at that stage. There's a number of people who've got significant responses with second-generation TKIs and have major toxicities who now can go back to imatinib as a maintenance TKI. And she could probably be maintained on something like imatinib, 300 milligrams once a day, which might be the safest of all the drugs you could put her on. So if you're talking long-term, that's fine. Again, I don't think TFR is an option. And with her response, you're not going to transplant her. But I think she should get down to 400 twice a day soon, because that's asking for trouble.
Yes, our choice would be to reduce to 400 because we don't have available 300 nilotinib.
You only have the 200 milligram pills.
We have only 200 milligrams dose only for the public system. Yeah.
Wow. Okay, then what I would do would probably go down to 600 once a day and then down to 400 once a day.
Yeah.
So that is my reduction.
That would be a choice. And we also don't have bosutinib in the second line.
I wouldn't touch her. I wouldn't touch her with bosutinib. Not with that pulmonary hypertension. That's right off the table.
Yeah.
David, what do you think?
Yeah, I am sympathetic, because when nilotinib was introduced to the Australian landscape, our government also did something dumb, which said that if you were in the second line, you had to use 200 milligram tablets and use a 400 milligram BD dose, whereas if you're first line, you can have access to 150 milligram tablets. But as Jeff said, I think I agree with Jeff. I think you should try to use the lowest dose of whatever TKI you're comfortable in, reducing long-term toxicity and trying to maintain response without causing this young woman further trouble. As Jeff said, I think 140 of dasatinib is really out of favor now, and we tend not to use that. And I think for those of us who are tempted to even use 100, just a reminder that if you were to do that, do not split the dose into 50 milligrams twice a day. If you were to use 100, use it once a day, because the toxicity is high if you split the dose. But yes, I think to add to the data of the dose reduction strategy, Richard Clark's Destiny study does show very well that for those patients who have achieved and maintained their deep molecular response, the probability of maintaining that response on a reduced dose is actually very good.
Lilian, do you have any comments you'd like to add?
About the dose, there's some investigation about taking dasatinib in first line 5 days a week instead of 7 days a week, and they have the same results.
At what dose?
At 50 milligrams, I think.
It may very well be. I think you might want to consider it, but I think I would wait till you got at least a 1% or a 0.1% response before you reduce to that. I haven't seen that study, so I don't know. But again, I hadn't started someone on anything higher than 50 once a day for years.
Lilian, do you have a final comment there? And then we'll move on.
No, no comments in this case. There was a question in the chat from Carolina Barreto from Uruguay that she has a patient that's 59 years old that was diagnosed in the year 2000 and was resistant to imatinib, nilotinib, dasatinib, and was studied to see if he had a T315I mutation and was negative, and started ponatinib, 45 milligrams, but he had side effects, leukopenia, thrombocytopenia, and was reduced to 45 milligrams alternate with 30 milligrams. But she's asking if asciminib would be an option in this patient. It doesn't say how is his response at the moment.
I think she said that the response was no response, no molecular response, right? In the chat.
Oh, yes.
Yes.
No molecular response.
So
Yeah,
perhaps
I can't talk about asciminib. I'll defer to David, but now remember the results of 45 once a day and 30 once a day, and even to a lesser extent 15 once a day were not that much different in non-T315I patients. So you can go to a lower dose and get the response, but I'll punt on to asciminib. David has much more experience.
Yeah, thanks, Jeff. I think if you're not getting the response that you need and you could get access to asciminib, then I think it's worth trying. I think, as Jeff said, the long-term toxicity data is yet to be accumulated, but I think at least in the last few years that we've had access to the drug, it seems that the drug is fairly well tolerated. So I think the calculation is if you could get access to it and you're not getting the response with the current drug, then I think it's worth trying. And in the Assemble study, I think there were actually no. I was just going to say in the Assemble study, I think there were some ponatinib failures. I don't think that's the case, but in the phase 1 study, there were definitely ponatinib failures that did respond to asciminib, but the rate is not high.
I think part of the problem with the ponatinib failures is they never made clear whether they were ponatinib failures because of intolerance or resistance.
Yeah.
That would be a big difference.
Yep. Difficult.
Great discussion as always there, and but I think we'll move on, Katia, to your second case. Any other questions in the chat or which haven't come up, just take them to the end to after Katia's second case, please.
So this is my second case. This is a patient that was 50 years old at diagnosis. He was followed by the infectology department because he had HIV in treatment, and in his regular consultation, they observed leukocytosis. That's the reason they referred the patient from the hematology. So the patient had a normal hemoglobin and platelets, but had a leukocytosis with left shift. And then we made the diagnosis of CML in chronic phase, low risk SOCAL. And the patient was already in treatment with antiviral drugs, but he was controlled. And then he started imatinib and achieved MR4, stable MR4. Next, please. 10 years later, he had a gastrointestinal bleeding and he did a colonoscopy. It was diagnosed a rectal adenocarcinoma. And so the oncologist's plan was to give him radiotherapy and chemotherapy, oxaliplatin and capecitabine. And they asked if imatinib could be interrupted during the treatment. And as the patient was in stable MR4 for many years, we did a TFR attempt. But then the patient failed. In 2 months, he lost the response. So we had to introduce imatinib, and then later we reduced the dose because he was worsening his renal function. I'm going to show you the tests. Please, next one, please. So this is the baseline renal function. We had a normal creatinine, and we had a normal estimated glomerular ratio. In 2018, the creatinine was increased, and now in 2024, we have a higher creatinine and lower eGFR. Next one, please. So after many years of TKI treatment, this is something that we can see in many patients. This picture shows schematically some mechanisms of the renal dysfunction. The most common that almost all of them, but mainly imatinib and bosutinib cause, it's the PDGFR inhibition that causes an impairment of tubular regeneration in the glomerulum. And also dasatinib may affect some pathways that are involved in the cytoxalectal alterations of the renal, of renal. And also ponatinib may inhibit VEGFR, which also causes renal impairment. TKIs may have effect also in the endothelial cells of renal endothelial cells, also causing thrombotic microangiopathy, mainly ponatinib and nilotinib. So there are many ways that TKI can affect renal function. Next, please. In this work, evaluating patients treated with TKI, we see that the estimated glomerular filtration rate changes during the treatment, but it's worse for imatinib. And in this study, they saw that 4% of the patients develop acute renal injury in the first year of treatment, but these cases were managed and none of these patients needed treatment interruption. Next. And then this is data from the bosutinib trials in first phase 1 and 2 and phase 3. They observed that older age, lower eGFR, and also previous hypertension are the most associated with development of grade 3 reduction of eGFR. So this is a toxicity that we have to be aware that exists and monitor the patient. Next. Well, regarding this case, I think there are some aspects that are interesting to talk about. One is the renal dysfunction. What to do if the patient has a renal dysfunction at baseline, and what to do if the patient develops renal dysfunction during TKI treatment. And when this happens during the treatment, when do you switch? What are your clinical parameters that you consider to switch TKI? Because, and before switching, if you try to dose reduction, and for how long? Because sometimes the decision to switch, we have to think about the other comorbidities that the patient have, because you will change a side effect for another. So this is something that you have to think about, how to balance when you have to switch because a toxicity. And another aspect that I think it's interesting in this case is the second malignancy, because we see many patients with ML that are living longer that have a second malignancy. And how are the general recommendations during the treatment if the patient has to go to a chemotherapy or radiotherapy? What do you do in practice? And another discussion about drug interactions, not only in HIV, but also in the general practice how to deal with this. I think these are my questions.
Let's start with Jeff.
We go back to, okay. Preferred, well, I think the drug that's probably in the long term shown to have the worst side effects in renal might be imatinib. But I think there's one thing you have to check. If you've got a patient where you see renal dysfunction on imatinib, the first thing you should do is hold the drug for a week. Now, why do I say that? Our colleagues in France, Delphine Ray, showed about 10 years ago that there are two effects of imatinib. One is this chronic effect on raising creatinine, but it's also as imatinib blocks the tubular excretion of creatinine. So if you hold the imatinib, that problem resolves within less than a week. So first of all, there is a group of individuals like that. So before you start thinking the kidneys are failing, just make sure that that's it, because it's a relatively benign condition and I wouldn't change things. I think you can use, depends how bad the renal dysfunction is. I think you can use any of the drugs, and I'm not sure that there's necessarily dose reductions. I think probably with the renal dysfunction, I would probably go with low-dose dasatinib as my first choice at 50 or less and go from there. When do I switch? Let's be practical. How old is your patient? What are the comorbidities? How bad is the kidney function getting? Is it getting to a stage where they'll die at the age of 80 or 90 but still not going on dialysis with elevated creatinines? Or is it getting to the point where they're heading towards frank kidney failure, where they might have to go on dialysis or get a kidney transfer? If you've got a very slow change in creatinine, you may not want to do anything, particularly if it's an older patient who you're not going to have to worry about a transplant or dialysis. When you switch, if it's an acute jump and they really start getting in trouble, you switch immediately. I wouldn't do a dose, or you can try a dose reduction, imatinib down to 400 or even 200. Again, taking into account the size of the patient and the ethnicity of the patient, which may have an impact on how they do things. And try it and see how it happens over about a 3-month period. Well, the comorbidities, I guess the first thing you always decide with a patient when you're choosing a drug, whether it's first, second, or third line, is what drugs are available for that line of treatment based on what the resistance or the intolerance are, number one. You then look at those drugs, then you decide on which of those drugs is safest for that particular patient and their comorbidities. So it's not one answer. Thirdly, then you have to get into a situation where you may face, and we face it in Canada too, what drugs are approved at that line of therapy and reimbursed. There's no good point saying I want drug X when drug X is not approved. So you may have to work with that as well. And this is an issue many of us have. Not everybody has access to every drug at every cost, so that's a big issue. How do you balance? Well, again, as a disease progresses, then you run into a problem of, the risk-benefit changes, and you may have to take a drug with more toxicity. So I think you have different decision points at each point. I have treated about 30 patients with second malignancies. CML patients are not living long enough that they're going to get other cancers. Women have a 1 in 8 breast cancer risk. There's all these other risks going. Men, at 80 years of age, men probably have a 40% chance of having prostate cancer. On only one case of a bad bladder cancer have I ever had to stop the TKI during chemotherapy and radiation therapy. Remember, everybody worries about suppression and things like that, but our drugs, if you get a good response, these drugs for the most part are not suppressing normal cells. So they're not going to worsen the cytopenias that you would associate with chemo or radiation therapy. And there's not a lot of drug interaction. I have more drug interactions with choosing the wrong statin or things of that nature. So again,
yes, I agree with you. Yeah, I agree with you in this aspect because Usually I don't interrupt. I interrupt in this particular case because he was he had a TFR criteria, and I thought it would be better for him to take less drugs during the treatment. But in general, I agree. We have other cases that we proceeded with the treatment with no major problems. But it's also a question that oncologists always ask us.
Yeah, always. And in your
Always.
case, it's very complicated. He got treated with oxyplatinum. And I don't know where the radiation field was as well, but that could have easily have contributed to his decreasing renal function, as well as the demand. And maybe the imatinib, I'm not saying it isn't, it may be both, maybe one or the other, but you know, platinum compounds do great jobs on kidneys, all of them. So there's that possibility. In terms of drug interactions with HIV and CML, I have a patient, a Vietnamese gentleman, HIV since 1990, who's got undetectable disease with a 5-log reduction standard in our lab, maintained imatinib full dose and on his HIV medications. I think you're fine for the most part. And I don't think just because they've got HIV, you back off.
David, would you like to share your experience with us? What are your thoughts?
Yeah, I agree with what Jeff has said. I don't know well, I agree that, as Jeff said, the effect on renal function seems to be more profound with imatinib as opposed to the other TKIs, and I'm not sure whether that's because we had the most experience with imatinib or whether it is true. And in practice, I find it very difficult to predict who will get renal dysfunction and who wouldn't. But as everybody has also said, there are other reasons in this guy, in this patient for renal dysfunction. I wonder whether any of the antiviral medications contribute. I wonder whether the HIV itself, if not well controlled, obviously we know that HIV itself can also contribute to renal dysfunction. And as Jeff said, the radiotherapy. I also wondered whether the cancer is a combination of the HIV as well, because it was an anal cancer, wasn't it? And I wondered about human papillomavirus infections. But on the CML points, I agree. I think, you know, if someone has renal dysfunction, I think the first cause is to actually find out whether the TKI is responsible by temporarily stopping the drug and see if the renal function recovers, and then go from there and trying to see which one is not going to be responsible. And I agree with the choice of low dose dasatinib as the second thing to try. As to drug interactions between HIV and CML, we recently had a young girl of 20 who has had HIV concomitantly diagnosed with her CML, and we've got very good pharmacists. We find that for most TKIs, the interactions between that and antiretrovirals is minimal with the new class of antiviral drugs. But obviously, depending on what you have available and what you're using, do check with your pharmacist.
Okay, folks, I think our translation is about to end, but this is, again, it's a great discussion. If our experts and others in the audience, if you can hang around for another few minutes, it'd be great to get Lilian's thoughts and then see what Katia's response. But I think the translation might stop. I'm not sure what that's going to look like, but I think we'll just, I'll keep going and say, Lilian, would you like to make a contribution to this discussion as well?
I was wondering if in patients with renal dysfunction, is it useful to take blood levels of imatinib or the drugs in general? How do you apply that test, or do you recommend it?
We can't get them, so from that point of view, I think when most of the drug level studies were done with imatinib many years ago to try and see about getting it in the therapeutic range, And I'm not sure that there was much toxicity if it was out of that therapeutic range. So I'm not sure about how valuable blood levels would be.
Okay,
We have done the occasional one, and I agree. I think I would just dose to response and toxicity.
okay.
Katia, what do you think?
Yeah, no, I agree with all the comments. Just for the patients that we had experience that are using imatinib and they go to TFR, some patients really improve the renal function after stopping treatment. We have seen it in the TFR case that we're using imatinib. So, but that's the most difficult for me is what Lilian commented, when to decide to switch, because the renal function goes slowing down over the years, but you can't predict who you're going to dialysis or not. And so the time to do that is, I think it's the most difficult thing to decide when to do it.
I think sooner rather than later in a younger individual.
Mm-hmm.
You know, if you have older individuals, probably it's not going to be much of an issue during their lifetime.
Yeah.
But it's really, it's got to be what you're comfortable with. And if you're not comfortable with that level of kidney function on that drug, then you have to make the change.
Mm-hmm. Right.
So any final comments and questions there?
Arlene, will we have time for the last case
I
of
think
Dr. Cardemil?
We're over time anyway, and I think we've lost our translators. It always happens. We think we have so much time, but the discussion is so rich about these cases. But we have your colleague's case, and we will present it alongside the webinar. So we have it. We won't forget it. We will present it with the webinar. And on the topic of such complicated and interesting cases, please can I invite you to visit our website at our Knowledge Centre and have a look at our case discussion site. Our online case discussion forum is where you can bring your most complicated and difficult cases and questions. We will take them to experts, get a response to, as I said earlier, the most complicated and difficult of all the cases go to Jeff. So thank you very much for joining us today. It's been a great discussion. We hope to see you soon. The third and final of the Latin American discussions of this series will be on 12 September. We're going back to the laboratory. Look at the lineup of speakers here. It's going to be a great discussion. We hope to see you online. Please visit the website, visit our Knowledge Centre. It really is a wealth of knowledge. There are many dedicated modules and a new module, Next Steps in CML Management, almost ready to be released. We'll keep you up to date with what's going on in CML, what's new. You can sign up for our newsletter. We'll send you papers of the month, information about upcoming meetings, webinars, and summaries to conferences and discussions. You might like to join our social media outlets, Facebook, Instagram, X, or whatever you prefer to engage with. Okay, thank you everyone, especially our experts. It's been a fantastic discussion as always. Thank you very much to our audience for being a part of this, and we hope to see you again on September 12th. Thank you very much.